Hello and good afternoon to everyone. Thank you for joining us for this symposium. My name is Said Torshizi, and actually the chairman of this symposium was Dr. Gilman, but unfortunately he didn't feel well and couldn't join us. It was a great honor to have him here, but that wasn't possible. He has the experience of more than 20 years of working on kynurenine pathway. That is the title of our symposium. Even at least I know that at least one of our presenters is his student. So we are not so far from him. And he's the, let me be precise, and he's the NHMRC Leadership Fellow of the Macquarie University Center for Motor Neuron Disease, Department of Biomedical Science in Sydney. And so we have some colleagues of him here, fortunately. Hello. We have some colleagues of him here, fortunately, and we will be we will enjoy the discussions here, hopefully. So before everything, let me draw my mask away, because everybody here is far enough from me, and there is no danger of contagious diseases here for COVID-19. So now I draw my mask away so that I can speak better to you. Again, I thank you for joining us. First of all, let's have an introductory video for our discussion here. Let me say the title of our symposium here. Our title of the symposium here is the kynurenine pathway, the role of kynurenine pathway in health and disease. So let us have this introductory video. Please run the first video.
Hey everyone, in this lesson we're talking about tryptophan metabolism and the kynurenine pathway. So to begin, tryptophan is an essential amino acid. It is important because it is the precursor for production of 5-hydroxytryptamine or serotonin, and it's also important for the production of melatonin. And tryptophan is degraded by the kynurenine pathway. Now the kynurenine pathway is the pathway that metabolizes and degrades tryptophan, and interestingly it is activated by stress signaling hormones. We'll talk about a bit more about that a bit later. And the two end products of the kynurenine pathway are quinolinic acid and picolinic acid. We'll also talk about these end metabolites a little bit later. So if we have tryptophan, tryptophan can be metabolized into 5-hydroxytryptamine or 5-HT. But if it's degraded, it can be acted on by two other enzymes: indoleamine 2,3-dioxygenase or IDO, or tryptophan dioxygenase or TIDO. And these two enzymes will both process tryptophan into kynurenine. Interestingly, these two enzymes are activated by different cytokines. Indoleamine 2,3-dioxygenase is activated by interleukin 1, interleukin 6, and tumor necrosis factor. And tryptophan dioxygenase is activated by the stress hormone cortisol. So stress and alterations in the immune system can actually activate these two enzymes that can lead to the metabolism of tryptophan into kynurenine. Kynurenine can then be metabolized by the enzyme kynurenine aminotransferase 1, 2, and 3 into kynurenic acid, or it can be metabolized by the enzyme kynurenine hydroxylase into 3-hydroxykynurenine. And essentially this enzyme attaches a hydroxyl group to this hydrocarbon ring. And once we've actually shunted tryptophan away from the production of 5-hydroxytryptamine into this degradation pathway, we've essentially reduced the production of serotonin. We've reduced the levels of serotonin, and that's why the kynurenine pathway has been implicated in issues with serotonergic functioning and also with psychiatric health issues. We'll talk more about that a little bit later. Nonetheless, once we have 3-hydroxykynurenine, it can be acted on by the enzyme kynureninase to 3-hydroxyanthranilic acid. This can then be acted on by the enzyme 3-hydroxyanthranate 3,4-dioxygenase to 2-amino 3-carboxymuconate semialdehyde. And then this can then be further broken down into the two end metabolites, picolinic acid and quinolinic acid. Quinolinic acid can then be further metabolized into the important cofactor NAD. And I just want to talk a bit more about the kynurenine pathway and its end metabolite, quinolinic acid. Quinolinic acid is an interesting end metabolite in that it itself has a neurotoxic effect. It is also an NMDA receptor agonist and has been shown to be associated with or involved in several different psychiatric disorders. And in fact, there are also other disease states that are associated with alterations in the kynurenine pathway and its end metabolite, quinolinic acid. We talked briefly about how the kynurenine pathway may result in reduced serotonin production, which would reduce serotonergic activity and may lead to psychiatric issues such as depression. But other diseases that are associated with issues in this pathway, one of those disease states is hydroxykynureninuriia, which is a genetic condition due to deficiency in the enzyme kynureninase. Other diseases that are associated with the kynurenine pathway and quinolinic acid is mood disorders such as major depressive disorder. We've mentioned this again because of that reduced serotonergic activity and function. Interestingly, ALS, so amyotrophic lateral sclerosis, has also been associated with disruptions in this pathway. And Parkinson's disease has also been associated with issues in the kynurenine pathway. And there's several other conditions that are associated with issues in the kynurenine pathway as well that I haven't listed here. So anyways, guys, that was a brief overview of the kynurenine pathway and tryptophan metabolism. I hope you found this video interesting and helpful. If you did, please like and subscribe for more videos like this one. And as always, thank you so much for watching, and I'll see you next time.
Some of the best researchers in this field, and we are glad to have this privilege. And for that, we should thank the hard work of so many people here that try to help this Congress. And in particular, Dr. Mehdi Rezayat, the president of this Congress, and Dr. Mahmoud Qazi Khansari, the executive manager of this Congress. We thank them truly as they gave us this opportunity. So let's not to spare any more time, not to waste any more time, and get straight to our first presenter. And we are honored for this opportunity. And our first presenter is Dr. Sevda Shayeste, the PhD of Pharmacology from the Tehran University of Medical Science. And her presentation will be focused around kynurenine pathway in cirrhotic cardiomyopathy. And she will share her expertise and expert opinion about that. Dr. Shayeste, do you have my voice? Do you hear me?
Hello.
Hello. Welcome. Thank you for joining us.
Good evening. Thank you very much.
Good evening to you too.
Thank you very much. I'm ready.
And we are honored to hear your presentation. I say
Thank
goodbye.
You very much. Goodbye. I will start my presentation. Okay.
Yes, of course. We do have your slides and your voice.
Okay, thank you very much. Okay. In the name of God, I'm Dr. Sevda Shayeste, and I'm pleased that I've got the opportunity to speak about tryptophan kynurenine pathway in cirrhotic cardiomyopathy, which was the last research topic of our studies in Tehran University of Medical Sciences. I'm thankful to the supervisors of this study, Dr. Ahmad Reza Dehpour and also Dr. Girst Gelman. Okay, I will first start with introducing this pathway. Of course, it was briefly introduced in the introduction video, but I will just briefly explain it. As you know, tryptophan is the essential amino acid of the body, and it has two metabolism pathways. As you see, the serotonin pathway and the kynurenine pathway. Although the serotonin pathway is more known, the kynurenine pathway accounts for about 95% of tryptophan metabolism. This pathway starts with the cleavage of tryptophan to kynurenine, and here you can see the two important and rate-limiting enzymes, IDO and TDO. Tryptophan deoxygenase and endolamine deoxygenase. TDO is the constitutive form, and the IDO enzyme is an inducible enzyme. So as you see, then kynurenine is converted to kynurenic acid or the other metabolites that were mentioned in the introduction video, 3-hydroxykynurenine, 3-hydroxyantranilic acid, quinolinic acid, and picolinic acid, and the last one, NAD. But we will focus on the first part of this pathway, tryptophan, kynurenine, and kynuric acid, due to time limitation, and because we just focused on this part of the pathway in our research. Okay, IDO enzyme was not very well known until Mann and Miller just revealed that IDO expression is necessary during pregnancy because its activation prevents the recognition of paternal antigens by immune system. And also further research revealed that IDO enzyme overexpression results in tumor escapes. So IDO was considered as immune inhibitor, and the IDO inhibitors were added as adjuvant therapy to chemotherapy regimens. But further research showed that an IDO enzyme is overexpressed in autoimmune diseases like rheumatoid arthritis or IBD, and inhibiting these enzymes just reduces the disease symptoms. So the theory changed, and IDO was considered as immune modulators rather than immune inhibitor or immune activator. And the fact is that this pathway is upregulated by systemic inflammation. And as you see, inflammatory factors such as interleukin-6, interferon gamma, or TNF-alpha induce the IDO activity and shift the tryptophan metabolism pathway toward kynurenine pathway. The primary studies were done on a kynurenine pathway and its involvement in neurologic diseases like Alzheimer, MS, seizure, motor neuron diseases, and they revealed that there is a relationship between the levels of kynurenine pathway metabolites and the severity of these diseases. And the metabolites have various effects. Some of them are neuroprotective and some of them are neurotoxic. Also, studies were done on the receptors of these metabolites, and they showed that kynurenine acts through aryl hydrocarbon receptors, and kynurenic acid has various receptors. It is the agonist of GPR35 and aryl hydrocarbon receptors, and it is the antagonist of glutamate receptors and alpha-7 nicotinic receptors. So this was just a brief explanation of what is the kynurenine pathway and what are the roles of this pathway. And in this slide, I will just briefly explain what is the cirrhotic cardiomyopathy disease and why was this disease important. As you know, cardiomyopathy is one of the complications of cirrhosis in patients without pre-existing heart disease. It is characterized by impaired chronotropic response to physiologic or pharmacologic stimulation. And the importance of this disease is that due to massive peripheral vasodilation, usually the cardiac abnormalities are masked and the ejection fraction usually remains normal. And this leads to delayed recognition of these patients. And unfortunately, most of the patients are lost after liver transplantation, which is the final solution for this disease. And regarding the difficulties of finding the donors and the difficulties of their surgery, just detecting these patients is very important, and detecting biomarkers and also finding therapeutic targets are of great importance. And regarding this fact that cirrhotic cardiomyopathy has a great relationship with systemic inflammation, and as we mentioned, that systemic inflammation triggers the IDO and just kynurenine pathway. So we were encouraged to evaluate this pathway in cirrhotic cardiomyopathy. Of course, when we just reviewed the literature, we found out the relationship between this pathway and cardiovascular diseases. For example, in 2017, it was reported that in atherosclerosis, endothelial inflammation activates kynurenine pathway by inducing IDO enzyme. And kynurenic acid level can be a biomarker for initiation and progress of this disease. Also, it has been reported that activation of this pathway predicts early death in patients with cardiac arrest. Also, a study in 1992 reported that the amount of accumulated kynurenine is associated with the stage of the cardiomyopathy disease. And also, kynurenine and kynuric acid can alter the activity of cardiomyocytes by affecting the respiratory rate in mitochondria. Also, there were studies that revealed the relationship between cirrhosis and this pathway. Claria reported that patients with higher level of kynurenine pathway activity are more susceptible to experience acute on chronic liver failure. And also the urinary kynuric acid level may be a potential biomarker for diagnosing hepatic fibrosis. Also, it has been shown that in a BDL model of liver cirrhosis, the inhibition of IDO enzyme reduced the hepatic encephalopathy symptoms. And also, it was reported that in HCV-infected patients, the higher expression of IDO leads to the development of hepatocellular carcinoma. So taken together, all of this information and data just encouraged us, as I mentioned, to evaluate this pathway in cirrhotic cardiomyopathy, because this disease is a mixed disease between the cardiac and hepatic tissues. So for this purpose, cirrhosis was induced by bile duct ligation method in rats. And as you see, groups were divided to control group, BDL group, and the treatment groups. There were BDL-induced rats which received 1-methyltryptophan in doses 1, 3, and 9 milligram per kilogram intraperitoneal and with single injection in day. And 1-methyltryptophan was used as IDO inhibitor. As I mentioned, because we hypothesized that this pathway is upregulated in cirrhosis due to systemic inflammation, maybe the inhibition of this pathway could help to just reduce the complications of cirrhosis. So we used 1-methyltryptophan as an IDO inhibitor in this research. Of course, we had groups that received the vehicle, the normal saline instead. Okay, 28 days after BDL induction, cardiac chronotropic response to epinephrine was assessed ex vivo. Serum samples were collected and they were used to measure ALT, AST, and total bilirubin for liver function. Also, serum samples were used to measure CRP and interleukin-6, the important inflammatory markers in cirrhotic cardiomyopathy, by ELISA method. And HPLC was used to measure hepatic and cardiac levels of tryptophan, kynurenine, and kynuric acid. As I mentioned in previous slides, we focused on the first part of this pathway. And in this study, kynurenine to tryptophan ratio was measured as IDO activity indicator. And we just reviewed the previous studies, and regarding to this studies and to previous references, kynurenine to tryptophan ratio was measured as IDO activity indicator. Our results showed that cirrhosis was associated with impaired cardiac chronotropic response. It was expected, and it showed the cirrhotic cardiomyopathy. And 1-methyltryptophan, the IDO inhibitor, dose-dependently improved the cirrhosis-induced chronotropic dysfunction. CRP and interleukin-6 were elevated in BDL rats, and 1-methyltryptophan administration reduced the CRP and interleukin-6 levels. Hepatic and cardiac kynurenine to tryptophan ratio were elevated in cirrhotic rats, which showed us that the IDO was overactivated in cirrhotic rats, and this ratio was reduced following 1-methyltryptophan administration as it inhibited the IDO enzyme. And also cirrhosis was accompanied by the manifestation of elevated AST, ALT, and bilirubin levels, and also liver fibrosis, inflammation, and enhanced ductal proliferation. And surprisingly, 1-methyltryptophan reduced the ALT, AST, and bilirubin levels, as well as hepatic inflammation, fibrosis, and ductal proliferation. So in this study, the parallel increase of kynurenine and kynurenic acid levels and the chronotropic dysfunction were similar to previous studies which indicated the abnormal kynurenine pathway in cardiovascular diseases. 1-methyltryptophan administration, or in other words, IDO inhibition, and reduction in kynurenine and kynurenic acid levels were associated with a marked improvement in chronotropic dysfunction. And of course, the relationship between these metabolites and the signaling pathways involved in cirrhotic cardiomyopathy suggests us a role for kynurenine pathway in CCM disease. As you see in this slide, there are various signaling pathways that are involved in cirrhotic cardiomyopathy development. First of all, beta receptors are downregulated in cirrhotic cardiomyopathy, and the signaling pathway is impaired, and also endocannabinoids are elevated in cirrhotic cardiomyopathy, and as they act through CB1 receptor, they reduce the adenyl cyclase activity and they reduce the CAMP level. And besides the mentioned signaling pathways, nitric oxide and carbon monoxide levels are elevated in cirrhotic cardiomyopathy. They increase the cGMP level, which is a negative inotropic mediator, and they again reduce the CAMP level. So again, they contribute in cirrhotic cardiomyopathy. Also, the function of calcium, L-type calcium channels are impaired, and all of them together lead to cardio depression, and these are the major signaling pathways that are impaired in cirrhotic cardiomyopathy. And here we will just discuss the relationship between the kynurenine and kynuric acid metabolites and these signaling pathways that were mentioned in previous slide. As I mentioned, kynurenic acid is an agonist of GPR35 receptor, and the activation of this receptor can impair the beta-adrenergic signaling by reducing the CAMP formation. Also, there is a reciprocal interaction between cannabinoids and kynurenine pathway metabolites. IDO enzyme can be induced by cannabinoids, while kynurenine has a crosstalk with cannabinoid receptor type 1 mediated signaling. Also, studies have reported that kynurenine elevation leads to nitric oxide formation, and as I mentioned, nitric oxide increase leads to cardiac depression and massive vasodilation, which is one of the struggles in cirrhotic cardiomyopathy. Also, studies have reported that the direct toxic effects of kynurenine pathway metabolites on cardiomyocytes, including impaired NADH-driven complex 1 activity and diminished respiratory rate, is another suggested mechanism for kynurenine pathway involvement in cirrhotic cardiomyopathy. Also, our results showed that IDO inhibition reduces the levels of CRP and interleukin-6 in cirrhosis. As you know, CRP level correlates with the severity of cirrhosis, and interleukin-6 is one of the important mortality predictors in this disease. So the reduction of CRP and interleukin-6 can be proposed as an additional protective effect of 1-methyltryptophan in cirrhotic cardiomyopathy. Taken together, we can conclude that kynurenine pathway is involved in cirrhotic cardiomyopathy, and inhibition of this pathway prevents the development of the disease. And this protective effect is not limited to cardiac function, as we observed that the liver function was improved by 1-methyltryptophan administration. So we can suggest that future studies will pave the way to understand how kynurenine pathway is involved in cirrhotic cardiomyopathy and how 1-methyltryptophan just protects the patients from cirrhotic cardiomyopathy. Okay. And thank you for your attention.
Thank you very much. Thank you very much, Dr. Shaiste, for sharing the results of your well-designed study and your comprehensive and informative presentation. Thank you very much. It was an honor for me.
Thank you very much. It was a pleasure to just speak about this topic, and I'm thankful to you and your colleagues.
Thank you. Thank you very much. You're welcome. And before we say farewell to Dr. Shaiste, let me talk to our audience and say that any participation, any contribution, questions will be encouraged and welcomed from our participants, and anybody who has any questions can type down his or her question in the chat box, and I will read the question for the presenters, and hopefully the answer will come after that. So please feel free to ask your questions and share your ideas with us. If there is no question and no comments, again, we thank Dr. Shaiste and we say farewell to her. Thank you, Dr. Shaiste, for your participation in this symposium.
Thank you very much.
Goodbye. And just for the record, let me say that we have 4 more presenters in this symposium, and our next presenter honorably will be Dr. Hamid Kazemi Shariat Panahi, the PhD candidate of Macquarie University in Sydney, Faculty of Medicine, and his presentation will be focused around kynurenine pathway and psychiatric disorders, and specifically major depressive disorder and suicide. So let's say hello to him and join the conversation with him. Dr. Panahi, do you hear me?
Welcome to my presentation titled The Association of the Kynurenine Pathway in the Neurobiology of Depression. Depression accounted for more than 27% of the total mental disorders in 2017, affecting 264 million people worldwide in the same year. In 2016, major depressive disorder claimed 1 life every 40 seconds due to suicidal behaviors. This high number of mortalities made depression the 2nd leading cause of youth death and 18th leading cause of death. Tryptophan is one of the 9 essential amino acids that human body cannot synthesize. Therefore, it must be supplied by diet. This amino acid has been identified as a precursor for biologically essential metabolites such as serotonin, melatonin, tryptamine, and niacin in the central nervous system. The kynurenine pathway is the main route of tryptophan catabolism. The association of inflammation and KP with depression and suicidality is well known. Pro-inflammatory cytokines, including interferon gamma, tumor necrosis factor alpha, and interleukin-1 beta 2 and 6 increase during depression. These pro-inflammatory cytokines could overactivate the KP. KP overactivation eventually leads to overproduction of quin, decreasing the hippocampal and amygdala volume. Inflammation can dysregulate the KP through the activation of astrocytes and macroglia. Within the brain, these cells are the primary sites for tryptophan catabolism. More specifically, kynureninic acid is produced mainly by astrocytes, whereas quine is the main product of tryptophan catabolisms by macrophages during NAD+ generation. However, during inflammation, macroglia produce pro-inflammatory mediators that could induce the Kp in the brain. The induced Kp in turn may lead to the production of neurotoxic Kp metabolites such as quine. These toxic metabolites may further decrease kynureninic acid by eliminating astrocytes. Lower astrocytes and higher macroglia numbers were observed in the patient with major depression. Large meta-analysis studies have demonstrated decreased tryptophan availability and noted decreases in kynureninic acid and kynurenine levels of depressed patients as compared to the controls. Additionally, there were significant changes in metabolite ratios, specifically kynureninic acid to quine and kynureninic acid to 3-hydroxyanthralinic acid that were decreased compared to non-depressed controls. Quine levels in the cerebrospinal fluid of suicide attempters were significantly increased, and NMDA receptor expression was also elevated, suggesting that quine's neurotoxic effects could contribute to the pathophysiology of suicide attempts. Tryptophan metabolism in the body can also be affected by gut microbiota that can metabolize tryptophan. These microorganisms can even produce some Kp metabolites, potentially driving depressive symptoms in some individuals. Additionally, gut microbiota is critical in the development and integrity of the blood-brain barrier and in the development of effective immune systems. Studies have demonstrated that gut microbiota dysbiosis is associated with central nervous disorders. Due to changes observed in depressed individuals, Kp metabolites have been targeted to discover biomarkers for identifying individuals that will respond better to a specific medication, distinguishing bipolar disorder from major depression disorder, or pinpointing depressed individuals who are at higher risk of suicide attempts. For example, a study showed that suicide attempters have lower ACMSD activity. This enzyme limits quine formation by competitive production of the neuroprotective metabolite picolinic acid. As a result, suicide attempters had lower picolinic acid to quine ratio compared to the normal control. In summary, the kynurenine pathway is dysregulated in the depressive patients. It can trigger depression by several mechanisms. Gut microbiota can change tryptophan and Kp metabolites availability. Kp alteration offer a viable starting point for formulating biomarker panels. For this purpose, we need to investigate the convergence points of gut microbiota, viruses, inflammation, and the Kp with depression. Thank you for your attention.
Thank you very much from Dr. Hamid Panahi for his informative and intriguing presentation. And one of our attendees asked about the slides, that how he can have them, how he can ask them, and the answer is that the slides will be uploaded in the YouTube channel of ISPP, the YouTube channel of ISPP, and you can download them from there. So let us straightly go to our next presenter, which is Honorably Dr. Gayatri Sundaram from New South Wales University of Sydney. She is a postdoctoral research scientist in St. Vincent Center for Applied Medical Research, and her presentation will be about kynurenine pathway and multiple sclerosis. She's a dedicated and renowned researcher that the focus of her research research has been on neurodegenerative disorders. So let us enjoy her presentation. Dr. Gayatri Sundaram, do you have my voice? Do you hear me? If you hear me, we are glad to say hello to you. Thank you very much.
I'm here to answer the questions, so maybe you can watch my recording.
Okay, what did you say? Excuse me. Can we play your presentation?
Yes, please. Yes, please.
Yes, yes. Thank you.
Good afternoon, everyone. Thank you for the invite. It's great pleasure to share our research work with you all. I'm here to discuss about my project, Kynurenine pathway in multiple sclerosis. Before moving into the project, I would like to explain how the tryptophan metabolism happens in the central nervous system. In the periphery, tryptophan is circulated via blood in the albumin-bound form. Since tryptophan has higher affinity for the blood-brain barrier transporter LTAA than albumin, almost 75% of albumin-bound tryptophan likely dissociate from albumin to be taken up into the brain. Within the brain, most of the cells use it for protein metabolism. Neurons digest the tryptophan to serotonin and tryptophan, whereas 95% of the tryptophan converted via kynurenine pathway. This is the simplified version of kynurenine pathway for tryptophan catabolism. Tryptophan is one of the 10 essential amino acids responsible for production of NAD for cellular activity. The oxidative metabolism of tryptophan leads to an increased level of L-kynurenine by activating IDO or TDO enzymes. The cardinal role of kynurenine is to serve as a precursor of the neuroprotective kynurenic acid and picolinic acid, and the neurotoxic compounds 3-hydroxykynurenine and quinolinic acid. So, why these individual metabolites are important in central nervous system during disease state? This study demonstrates that changes in the brain levels of certain Kp metabolites may be important mediators contributing to brain cell dysfunction in some neurological disorder involving increased Kp activation. Black bar is neurons and white is astrocytes. The left side graph represent NAD plus production and the right side one is LDH release. We hypothesize that while some of the extracellular Kp metabolites may be beneficial for intracellular NAD plus synthesis and cell survival at physiological concentration, but they may contribute to neuronal and astroglial dysfunction and cell death at pathophysiological concentration. In this study, we found that treatment of human primary neurons and astrocytes with 3-hydroxyanthranilic acid, that's 3-HAA, and 3-hydroxykynurenine, that is 3-HK, quinolinic acid, quin, and picolinic acid, pic, at concentrations below 100 nanomolar significantly increased the intracellular NAD plus levels compared to non-treated cells. However, a dose-dependent decrease in intracellular NAD plus levels and increased LDH release activity was observed in human astrocytes and neurons treated with 3-HAA, 3-HK, quinolinic acid and picolinic acid at concentrations more than 100 nanomolar and kynurenine at concentration above 1 micromolar. This study shows that not only these metabolites are important for producing cellular energy, it also shows that at pathological conditions, increased activation contribute to accumulation of toxins and cause damage to the cells. Even though kynurenic acid was discovered roughly 170 years ago, it was not until the 1980s and 1990s that the kynurenine pathway sparked substantial interest among neuroscientists. This was due to the discovery that the two major products of the pathway, kynurenic acid and quinolinic acid, possess significant yet opposing effects on various neuronal cells and physiological processes. The kynurenine pathway has been studied extensively since 1990, with a surge in the number of publications from 2010 to today, which becomes 3 times more than 2010, and it keeps increasing. Our group has characterized the kynurenine pathway in several brain cells, including astrocytes, microglia, and macrophages, and also neurons and oligodendrocytes. The KP branches into 2 major pathways, one implicated in neuroprotection and the other in neurotoxicity, that are segregated across cell types. Under physiological conditions, the neuroprotective branch is more active, as most of the kynurenine in the brain is metabolized into kynurenic acid, NMDA, and alpha-7 nicotinic acetylcholine receptor antagonist through the action of kynurenine aminotransferases, expressed mainly in astrocytes. Whereas under inflammatory conditions, the metabolism is shifted through kynurenine monooxygenase to produce 3-hydroxykynurenine and other toxic metabolites such as quinolinic acid, this is an NMDA receptor agonist and oxidative stressor. KMO is primarily expressed in microglia and the resident immune cells in the brain, and is also expressed in high levels in peripheral immune cells such as monocytes and macrophages. The KP in oligodendrocytes demonstrated that IDO1 and tryptophan 2,3 dioxygenase are not expressed in human primary oligodendrocytes. This potentially has strong implications for MS pathology. The lack of these 2 KP regulatory enzymes in oligodendrocytes is associated with higher cellular susceptibility to allogenic T cell challenge, since IDO1 plays a crucial role in immune regulation, particularly in suppressing T cell proliferation. Before moving to main part of the study, I will provide brief introduction about MS. Multiple sclerosis is a chronic disease of central nervous system with persistent inflammation and demyelination, resulting in varying degrees of neurological deficit. This is the most common disabling neurological disease affecting young adults and females. Approximately 2.8 million people worldwide are affected by this disease. The exact factors that initiate inflammation are still unknown, but it is generally believed that MS is caused by environmental factors in a genetically susceptible host that trigger a T cell autoimmune response against the central nervous system. Although viruses may trigger MS relapses, there is no definitive evidence that there is an MS virus or ongoing chronic infection of the central nervous system. Epidemiological evidence suggests that Epstein-Barr virus, an ubiquitous virus, plays a key role in MS. Oligodendrocytes are the primary neural cells affected in MS. So, we characterize the KP in primary oligodendrocytes and the cell line. We found that both primary oligodendrocytes and MO3.13 cell line did not express IDO. However, MO3.13 cells expressed TDO and thus is potentially able to catabolize tryptophan. Primary oligodendrocytes which lack IDO and TDO are unlikely to be able to degrade tryptophan. In order to test the quinolinic acid toxicity in vitro, we chose mouse oligodendroglial cell lines N19 and N20.1. Using immunohistochemistry, we have demonstrated the capability of both the cell lines to take up exogenous quine, and this indicates the quine is catabolized intracellularly in a time-dependent manner, as fluorescence intensity was directly proportional to the uptake of quinolinic acid. We then further assessed the cytotoxic threshold of such quine on quine uptake on oligodendroglial cells. A standard curve using commercial exogenous quine to assess the level of gliotoxicity by quine on N19 and N20.1 cells. This demonstrated a relatively similar level of tolerance in the 2 cell lines to quine. There was a notable trend indicating dose-dependent quine toxicity on oligodendrocytes, where the LD50 for N19 is 0.5 micromolar and for N20.1 is 1 micromolar for 72 hours. These LD50 values were chosen as a reference criteria for subsequent quine antagonism studies. To neutralize the queen toxicity, we have used the queen monoclonal antibody in this cell model. I have showed that queen monoclonal antibody neutralizing the toxic effect of quinolinic acid. Neurotoxicity of queen on oligonucleotide cell lines were decreased by increasing concentrations of queen monoclonal antibody. To analyze the KP, we have used the chronic progressive EAE mouse model induced with myelin oligodendrocyte glycoprotein and pertussis toxin. Clinical severity score was based on the approved clinical score. Score of 0 indicates normal. Score of 1 indicates limb tail and or hind limb weakness. Score of 2 indicates both limb tail and hind limb weakness. Score of 3 indicates partial hind limb paralysis. Score of 4 indicates complete hind limb paralysis and forelimb weakness. And score of 5 indicates moribund state. And this graph showing the clinical score of EAE mice and wild type control, and the disease severity also represented as area under curve. Compared to wild type control, there is a significant difference in the disease severity. We have also assessed the EAE associated CNS pathology in the spinal cord from mice at the peak of the disease and stained with HNE to assess the inflammation, and LFB and NISL to assess the myelination. Independent histological analysis of spinal cord revealed that there is an inflammation and demyelination in EAE-induced mice. To analyze the kynurenine pathway metabolism in the EAE disease progression, we have grouped these mice according to the clinical score. Cohort 1 indicates EAE score of 0.5 to 1, cohort 2 is 1.5 to 2, cohort 3 is 3 to 4. To find out whether the KP is activated in EAE disease mice progression, we have measured the kynurenine and tryptophan ratio as a measure of IDO activity. In CNS, this IDO activity is directly proportional to the disease severity. We have also observed that there was a significant difference between the least severe group compared to the most severe group, that is cohort 3 in both brain and spinal cord. This suggests that the induction of kynurenine pathway may be related to the progression of EAE. This trend is also observed in serum samples. The KP activation is further confirmed in IDO1 gene expression studies by real-time PCR in EAE-induced mice, brain and spinal cord. In injured site, the IDO is highly activated and the staining was more prominent. Based on this immunohistochemistry, we have confirmed that IDO is activated during inflammation in EAE-induced mice. We then measured the first diverging branch of kynurenine pathway. In the midstream branching, kynurenine aminotransferases 1 and 2 synthesize kynureninic acid from kynurenine pathway cardinal compound kynurenine. We have also measured the kynurenine monooxygenase to analyze the downstream catabolism. In both CNS and plasma of EAE mice cohort, there is a significant decrease in the production of kynureninic acid in comparison to the control. Within the CNS, the kynureninic acid is lowest in the spinal cord tissue of the most severe group compared to the early cohort, suggesting that the production of kynureninic acid may actually be compromised during disease progression. We then analyze the expression of two enzymes, namely CAT1 and CAT2, involved in the catabolic reaction of kynurenine to kynurenic acid by real-time PCR. Our results indicate that the expression of CAT1 and 2 were significantly downregulated, particularly in spinal cord tissues, in agreement with the observation of kynurenic acid content found in spinal cord tissue. Whereas in brain, only CAT2 expression was significantly downregulated. Further, KMO expression is more prominent in the spinal cord of EAE-induced mice. The last branching point within the KP occurs at 2-amino-3-carboxymucrate semialdehyde, where it gets either converted enzymatically to picolinic acid by enzyme ACMST or non-enzymatically to quinolinic acid. Again, quinolinic acid is metabolized to produce NAD by QPRT enzyme. Picolinic acid was significantly decreased in both periphery and nervous system of cohort 3 in EA-induced mice group than in control. We also noted a progressive trend of subnormal concentration of picolinic acid from cohort 1 to 3, suggesting a correlation between decreased production of picolinic acid and EAE disease progression. Quin, on the other hand, was significantly increased in both periphery and central nervous system of EA-induced mice in comparison to the control. This effect was more prominent in the spinal cord tissue, with trend of increasing quin production as a disease severity increases, that is from cohort 1 to 3. Furthermore, the expression of ACMSD was significantly downregulated in comparison to the control, thus validating this decrease of picolinic acid production in both brain and spinal cord tissue. Surprisingly, we found QPRT was significantly upregulated in CNS, indicating increased activity in the catabolism of quinolinic acid in EA-induced mice. This was further validated by immunohistochemistry of QPRT. In our study, quin concentration remains high in both periphery and central nervous system, suggesting that QPRT is very likely to be saturated, resulting in the accumulation of quinolinic acid. Furthermore, the levels of quin did not reach pathophysiological toxic threshold as of those found in other neurological diseases, suggesting that quin is chronically accumulated in the progression of EAE and may involve in neurodegeneration. We have also measured the NAD plus and NADH ratio and plasma NADH in healthy and EA-induced mice. We found that NAD plus and NADH ratio were significantly decreased in EA-induced mice. This shows that QPRT is saturated due to increased accumulation of quin and not able to produce enough NAD plus for the cellular energy. In order to test which cell type is responsible for the overproduction of quin in EA-induced mice, we have done the double staining with neuronal markers. We have found quin is co-expressed with microglial and macrophage cells, but not with neurons, astrocytes or oligodendrocytes. This shows that monocytic cells of the innate immunity, when activated, can produce pathophysiological amount of quinolinic acid suffice to induce neuronal cell death. It is also plausible that quin from these monocytic cells are secreted exogenously, which is then taken up by surrounding neural cells for catabolism, eventually saturating the QPRT level within those cells, contributing to accumulation of quin that subsequently leads to neurotoxicity. This may also partially explain for the observation of gradual rise in quin to reach its pathophysiological concentration given the short duration of disease progression. This is highly relevant in the context of chronic neurological diseases, particularly since damage from MS during early stages is mainly due to immunological dysfunction inflicted by adaptive immunity, while later stages of disease progression exhibits a distinct classic neurodegeneration manifestation corresponding to the activity of innate immunity. We have also assessed the kynurenine pathway in multiple sclerosis progression in human plasma samples, and we have found a similar trend in those MS patients. Several drugs that modulate the kynurenine pathway are under investigation by our laboratory and others. For example, for depression, for chlorokynurenine, and for myalgic encephalomyelitis, chronic fatigue syndrome, kynurenine, and there are several IDO inhibitors for phase 1, 2, 3 cancer clinical trials, and chemo inhibitors has been used successfully for preclinical studies. Kynurenic acid analogs are about to enter clinical trials for the treatment of epilepsy, a stroke, and possibly Parkinson's disease. And 2 KP analogs are in MS treatment, teriflunomide and lakinimod. And KP analog has reached the market in Japan as a potent immunomodulative drug for the treatment of MS, asthma, and dermatitis. In order to test KP modulators effect in EA-induced mice, we treated the EA-induced mice with 1-methyltryptophan IDO1 inhibitor, 100 mg per kilogram body weight for 7 days. intraperitoneally after the mice reached a score of 2. We found that 1MT treatment significantly decreased the clinical symptoms within 3 days of treatment, followed by the transient reduction in disease symptoms during day 6 and 7. Next, we modulate this pathway at mid-level by blocking the KMO using RO618048 at the dose rate of 100 mg per kilogram body weight for 7 days intraperitoneally. RO618048 treatment significantly decreased the disease severity compared to control. In order to test whether kynurenine has effect on multiple sclerosis, we treated the mice with kynurenine 200 mg per kilogram body weight intraperitoneally every day until day 10 at the same time as EAE induction. Red double arrow indicates the treatment period and the black arrow indicates the animal monitoring using standard clinical scale. In the left side of the graph, we showed that the mean clinical score of vehicle control, kynurenine treatment, and the blue indicates the AHR ligand positive control TCDD. The right side mean clinical score AUC showed that there is significant difference in mean clinical score between vehicle and kynurenine treated mice, and there was no significant difference between the kynurenine and TCDD. The prophylactic kynurenine treatment significantly decreased the disease severity and subsequent relapse. In a more clinically relevant treatment paradigm, that is therapeutic kynurenine treatment, otherwise called initiating the treatment after the clinical score of 2 and above, we have shown that there is not significant difference between vehicle and kynurenine treatment until 36 days. But after 36 days, kynurenine treatment prevented the relapse in EA-induced mice. The present study demonstrates for the first time that there is a parallel link between the degrees of chronic EAE clinical deficit and the levels of KP metabolites. This study further supports our data from the human MS samples and demonstrates that the KP metabolism is involved in the progression of MS patient and EAE mouse model. Increase in IDO activation and change in the production of bystander catabolites from the KP through the course of EAE disease progression showed that this pathway is activated differently at different stages of disease severity. Appropriately timed KP modulation is as part of the MS treatment helps to slow and possibly halt the disease progression. So these are our ongoing studies looking at a kynurenine pathway gene variants in MS patients and conditional knockout mouse models for KMO and QPRT. And there is a queen monoclonal antibody treatment in 3D organized cell culture with our collaborators. And I would like to thank Professor Bruce Prue and Professor Jill Schilliman. And I would like to thank my lab colleagues and my collaborators, my funding bodies. If you have any questions, please contact me through my email ID. I will answer as soon as I can. Thank you very much.
Dr. Sundara.
Yes, I am here.
Thank you very much for presenting your interesting and novel study. It was really instructive for me, and it was a real pleasure, and we are proud of your presence in our symposium. Thank you for accepting our invitation.
Thank you. Sorry for the background noise. I didn't realize that.
Excuse me, what did you say? Sorry for what?
I didn't realize the background noise was too bad.
No, it was too good. Thank you very much. It was a really comprehensive yet succinct lecture of you. There are questions. Excuse me, may I ask you the questions of the audience?
Yes, please.
Yes. The person who asked the question, firstly, thanks you for the great lecture of you. And he or she asked, may I ask if you have considered looking at combining the IDO and KMO inhibitors on your mouse model?
Yeah, that's a wonderful question. We are planning to do our next set of experiment on kynurenine pathway combinatorial treatment. but we also has to be very careful on NAD production as well, because if we block too much, we might be blocking NAD production. So we are careful on that part as well. So we're balancing both ends. So we will be doing combinatorial treatment experiments very soon.
Very good. Thank you. Thank you for your explanation. If there is no other questions, no further questions, we thank Dr. Sundaram and say farewell to her. Thank you very much, Dr. Sundaram.
Thank you so much. Bye.
Goodbye and have a good day.
You too. Bye.
Thank you. Bye. And here I am glad and honored to be joined by Dr. Javan and Dr. Mir Najafizadeh. Thank you for your presence. Thank you. And we'll continue to the next presenter, and we are honored to have a prominent researcher in many fields, including the relationship between kynurenine pathway and cancer. I am talking about Dr. Benjamin Henge from the Macquarie University of Sydney. He's a researcher at Macquarie Center for Motor Neuron Diseases, Department of Biomedical Science. I say hello to you, Dr. Benjamin Henge. Do you hear me?
Yes, loud and clear. And again, thank you for providing me this opportunity to present your wonderful.
I think Dr. Benjamin Henge is talking, but we do not hear him.
Oh.
Yes, yes. Now we have your voice.
I see. Sorry. Yes, thank you for the opportunity, and I'm enjoying this conference.
Thank you, thank you, thank you. We are enjoying the conference more than anyone else. Thank you for accepting our invitation. This is an honor to host you and the other collaborators to this field. I do not waste any more time by me speaking, so let's go to your presentation. The stage is yours. Thank you. And your presentation, I think, is about the kynurenine pathway and cancer, yes?
Yes, you're right.
Thank you. The stage is yours. We glad to hear you.
Yeah, I think I have it on recorded. I'm not too sure. Is it up?
Yes, yes, we do have it. We do have it. We can do that. Okay.
Yes. Thank you.
Yes, yes, yes. Go on, please.
I'd like to thank the organizer of the conference for providing this opportunity to present my research interests as well as my research project on kynurenine pathway and cancer. And in today's talk, I'll be talking about a brief introduction to cancer, the role of kynurenine pathway in cancer, clinical trials examining kynurenine pathway inhibitors, and last but not least, the research project that I've been working on in Professor Guillemot's lab on kynurenine pathway and breast cancer. First off, what's cancer? Cancer is a disease of cells that grow in an uncontrolled manner and spreads into the surrounding tissues. And according to World Health Organization, cancer is the leading cause of death worldwide, resulting about 10 million deaths this year. And the top 5 cancer-related deaths are lung cancer, liver cancer, stomach cancer, female breast cancer, and colon cancer. And if you can see the figure on the right, you can see that most of the cancer-related deaths are reported in the Asia, followed by America. And cancer can be categorized in various stages, and it differs from one cancer to the other. And in this talk, I'll simplify it to 2 stages. The first stage consists of cancer developed in an uncontrolled manner but contained within a locality. This means that patients diagnosed with early stage cancer tends to have the best prognosis, where it can be removed surgically and has the lowest risk of relapse. However, if cancer continues to remain undetected to grow, they then proceed on to late stage, which is metastasis, where the cancer actually breaks its boundary to invade surrounding tissues and other parts of the body. So patients diagnosed with this stage of cancer tends to have low survival rate and tends to have the worst prognosis. And for cancer to develop from early stage to metastasis, it needs to have or accumulate a number of factors. So these are known as the hallmark of cancer. So if you read from the top in green, it needs a sustained proliferative signaling, evade growth suppressors, activating invasion and metastasis, enabling replicative mortality, inducing angiogenesis, and cancer resisting cell death. And as technology advances, there's more hallmark has been suggested to add onto this existing hallmark, and they are the emerging hallmarks such as deregulating cellular energetics, avoiding immune destruction, and in enabling, you can see there's genome instability and mutation and tumor inflammation. And among all these hallmarks, KP has shown to have a strong association with the emerging hallmarks of deregulating cellular energetics, avoiding immune destruction by providing energy for tumor repair and growth, and at the same time avoid immune detection. So what's KP? As presented by Professor Guillerman yesterday, KP is a biochemical pathway that catalyzes tryptophan to generate energy for the cells to repair and divide. And this pathway is usually in a very strict controlled manner under healthy control condition. As you can see, IDO1 and TDO2 is the rate limiting enzyme of the pathway. And after breaking tryptophan down, there's a series of KP metabolites marked in red, shown to have bioactive activity and able to induce cell death. And the pathway tends to operate in a linear manner where tryptophan is being catabolized into series of metabolites to derive NAD+, which is the energy for cellular repair. Next, you might ask or wonder, how is KP involved in immune response? So the ability of KP to mediate immune response actually comes in a study led by Professor Mann in the US, where they noticed or observed that IDO1 is highly expressed in the placenta. And this actually prevents maternal immune system from attacking the fetal across the placenta. And in the same group, they treat the pregnant mouse with an IDO1 inhibitor that to stop the activity of IDO1 in the placenta. This allows the immune system from the maternal side to cross the placenta and attack the fetal, leading to fetal rejection. And as shown in the study, they then, given that KP is able to manipulate or mediate immune suppression, they thus wonder like whether tumor has the same ability, given that KP is expressed across almost all cells. And true enough, in the study led by the same team, they noticed that the tumor in the breast cancer mouse model, which is an MMTV HER2 mouse, the tumor expressed high IDO1 activity. And when they treat this mouse with an IDO1 inhibitor, it led to a slowed tumor growth. And interestingly and excitingly, when they combine it with the chemotherapy drugs, it actually caused a regression of the tumor. So now you might wonder, so how is KP involved in cancer progression or development? And this can be broken down into three different mechanisms, as you can see in the figure on the right. The first mechanism will be the tryptophan depletion or starvation. Tryptophan is an essential amino acid for immune cells survival and proliferation. And if you can see on the figure on the right, IDO1 and TDO2 tends to be highly activated in tumor cells that depletes the tryptophan in a microenvironment. And given that it's an essential amino acid, this stops the CD4 T cells, which is a tumor targeting cells. And by stopping it from growing, tumor cells are able to continue to proliferate. The second mechanism is the production of bioactive metabolites, which are highlighted in the slide earlier, which is 3HK, 3HA, and queen in green, turquoise, and dark blue. These three metabolites have been shown to inhibit, again, CD4 cell proliferation in a micromolar concentration. And finally, the last mechanism, which is the hydrocarbon receptor activation by kynurenine, which is the first product of the pathway. It is an endogenous ligand that binds to this AHR, and AHR receptor is expressed in almost all cell types in the body. However, binding to this cell type in various cells achieves different outcomes. For example, when it binds to the cancer cell itself, it enhances invasion and local inflammation, as you can see mark 3 here. And when it binds to the AHR expressed on CD4 cells, it actually causes it to undergo cell arrest. And inversely, when it binds to a group of T cells, which is called the T regulatory cells, they are known to suppress immune surveillance. It actually causes this cell population to proliferate. And this task creates an immune exclusive zone around the tumor. And given that, or considering that an inhibitor to the pathway is one of the most popular choice for treatment, KP-IDO1 has now emerged as one of the popular targets to regulate or to stop this activity. And currently, there's up to 97 different clinical trials examining IDO1 inhibitors. And these are the 3 prominent companies that manufacture and involved in clinical trials, which is the Incyte, Newlink Genetics, and BMS. And here are the various inhibitors provided or generated by these companies. And if you can see from the number of clinical trials, ipacadoside is the most popular one, which is involved in 59 because it has the highest IDO1 inhibition efficacy. And the next 2 it will be the indocimod and BMS inhibitor, where they're involved between 15 to 20. And from the clinical trials, it's been reported that these inhibitors are well tolerated with no increase in toxicity observed in patients. And the most common treatment emergent adverse events are fatigue, nausea, and anemia. And considering that these are in clinical trial, I'd like to highlight to you 2 of the prominent clinical trials happening now. So the first one would be the ipacadoside, which is the NCT 02752074, which is the idea of the clinical trial. This looks at the combination therapeutic treatment of ipacadoside with probrolizumab, which is a checkpoint inhibitor in patients with unresectable or metastatic melanoma. At the conclusion of this clinical trial, they observed or reported that patients receiving a combination therapy show no difference with the groups receiving the pembrolizumab only. And given this conclusion, this clinical trial did not proceed on to phase 3. This negative result actually led to a series of termination or pause in enrollment in other multiple IDO1 clinical trials. But I'd like to highlight or bring to your attention to what might have led to these negative results. First of all, inhibiting IDO1 alone might not be sufficient because studies has been shown that inhibiting IDO1 would have a compensatory mechanism of IDO2 and TDO2, where they became the prominent enzyme to drive the pathway. And next is in this clinical trial, the patient is actually not being screened. So they have no idea whether the tumor actually express IDO1 or not, or even TDO2. Hence, the result is not as positive as you would have if it's been screened. And these 2 points thus highlight the gaps in creating ideal clinical settings to evaluate IDO1 inhibitor efficacy. The next example I'd like to highlight to you is indocimod, which is the clinical idea of NCT 02073123. This clinical trial also looks at patients with advanced melanoma, where they evaluate combination treatment of indocimod with either one of the immune checkpoints. In contrast to ipacadoside, they actually observed that patients treated with the combination therapy of pembrolizumab with indocimod has a higher objective response rate as compared to patients with just pembrolizumab only. This means that patient undergoing or receiving the combination has a lower tumor burden or a reduction in tumor size as compared to patient with who receive only the checkpoint inhibitors. And given these positive results, it has now proceeded to phase 3 clinical trial. And as you can see from this example, it highlights that patient selection seems to be crucial or essential to have a clinical trial that can critically evaluate IDO1, and hence where my research project comes in, where we see whether we can use KP activity to screen for patients with breast cancer, which is what I'm doing in Professor Guilliman's lab. And this work has actually been published last year, where we look at KP expression in different breast cancer subtypes. To start off, I'll give you a brief introduction of breast cancer. So it is the most diagnosed cancer cases and the 5th cancer-related death worldwide. And it can be classified into subtypes according to its molecular characteristics. But for this talk, I'll simplify it to 3 major breast cancer subtypes. They are luminal, which depends on estrogen, HER2 enriched, which depends on the growth factor HER2, and triple negative, where it depends neither the hormone or the growth factor. On the y-axis is the risk of recurrence, where the lowest risk at the bottom, as you move up towards vertically, is risk of recurrence increases. And the x-axis is the prognosis, where on the left is the best prognosis. As you move towards to the right is the worst prognosis. As you can see, triple negative has the worst prognosis and higher risk of recurrence as compared to luminal and HER2 enriched. The reason to this is the absence of targeted therapy. So you can see that patients with luminal breast cancer subtype tend to have tamoxifen as a treatment, while patients with HER2 enriched breast cancer have the trastuzumab as a treatment. Interestingly, in patients, the triple negative tumors has the highest number of infiltrating immune cells. So there's a lot of immune cells around this tumor, but somehow the tumor is able to evade the immune surveillance or detection. And thus this suggests that perhaps these cancer cells have immune evasion ability to stop them from being detected by immune cells. Hence, the immune system is unable to control the cell growth, the tumor cell growth, of course. And this then led to the suggestion that perhaps immunotherapy might be a good treatment for them. And one of the target for immune therapy is the kynurenine pathway. So then that leads to the next question, as in, what do we know about kynurenine pathway regulation in breast cancer? There's about up to 20 studies now done, but I only highlight a few here in this talk. And I'd like to bring your attention to the number of the studies. They only look at the first enzyme, IDO1, and the first product, the kynurenine, in patients. And given that there's so many studies looking at the same marker, thus let me wonder whether it's KP activity limited just to IDO1, and that whether, given that they are all different subtype, different molecular profile, would KP behave differently or similarly across this pathway or subtypes, sorry. To do this, we then look at the mRNA expression of the KP enzyme in tumors. And this is done by using patients' sample or mRNA array data collected in by Molecular Taxonomy of Breast Cancer International Consortium cohort in collaboration with a collaborator from University of Newcastle in Sydney, Dr. Milio, Professor Moscato, and we look at a total of 1,500 patients and 144 healthy control. And in the IDO1 tumor expression, we saw that triple negative has the highest expression, followed by HER2 enriched, When we look at the second enzyme on the pathway, which is KMO, we saw that HER2 is actually highly elevated, followed by triple negative and Lumina. They seem to have the same expression. And when we look at the third enzyme down of the pathway, we saw that triple negative and HER2, and which again has the highest expression. There's no difference between Lumina and healthy control. And given that mRNA is not necessarily translate the protein, we then look at the the protein expression and tumor slides. So we look at we do immunohistochemistry, looking at IDO1, KMO, and KYNU, as you can see in the slides here, and the corresponding negative control, which is the isotype control to show the specificity. And the profile almost matches what we see in the mRNA, where Lumina has low expression across 3 different enzymes, while triple negative and HER2 enriched has high expression of IDO1 with KMO or KYNU. After seeing or examining the protein expression, we next wonder, like, okay, would that protein be active at all? So next we look at the enzyme activity in patients' blood collected from Victoria Cancer Biobank, Australia Breast Cancer Tissue Biobank, and Strathfield Breast Cancer Center in collaboration with Dr. Bustamante from UNSW and Dr. Gluck from Strathfield Breast Cancer Center. We look at about 300 or almost 400 actually breast cancer patients and 98 healthy controls. And it's almost the same as what we see in the mRNA and protein profile. Triple negative and HER2 enriched breast cancer patients has the highest activity. And same goes for KMO and KYNU, where triple negative and HER2 has the highest activation. And in conclusion of all these 3 profiles, we conclude that patients with triple negative and HER2 enriched breast cancer subtype has the most KP dysregulation. And given that we can measure all this activity on the blood, next makes us wonder, well, can we actually make use of this data? Given that we can measure the enzyme activity in different breast cancer subtypes. So next, we then collaborated with one of our university biostatistician, Associate Professor Lynch. We put all this data into predictive marker modeling, where we try to see if we can identify triple negative patients from Lumina and HER2 enriched. And interestingly, with all these parameters we measured in the blood, we're actually able to identify patients with triple negative subtype with a 95.2% accuracy. And surprisingly, this accuracy is near to the current gold standard done in pathological lab to identify patients sampled by doing IHC or immunohistochemistry. And you can see it's about sub-90s from here. And this task suggests that perhaps measuring KP enable us to screen patients for who can benefit from IDO1 inhibitor treatment. And conclusion of this study, this first study showed that the pathway is not limited to just IDO1. Downstream enzymes are also active in these breast cancer cells, and that they might evade immune surveillance by tryptophan depletion by IDO1 and the production of immune suppressive metabolites, such as by KMO and KYNU. Next, the dysregulation is predominantly seen in hormone-negative breast cancer subtype, which is the triple negative and HER2 enriched. This task suggests that perhaps these 2 subtypes, KP is one of the mechanisms used by the tumors to evade or prevent immune detection. Last point, which is the measurement of the KP metabolite in pre-treatment breast cancer, has a high prognostic identification to identify patients with triple negative breast cancer subtype, and thus have the potential as a treatment response perhaps, or identify patients that might benefit from IDO1 inhibitor treatment. And on this, I'd like to thank Professor Guillermin Group and his ever long support of my work in breast cancer, and also various institutes on organizations such as the Breast Cancer Network Australia, hospital, and various collaborators from Research Institute, and most importantly, the funding for me to proceed with this or support my research. And at this slide, I'd like to thank your attention and the opportunity again to present my work. Thank you.
Dr. Haynes, thank you very much for your participation and your very comprehensive presentation, highlighting the main points, the main aspects of this field of research for young and interested researchers and helping them to navigate through the literature. Of course, obviously, this is the fruit of years of dedication, and we thank you for accepting our invitation and participation. Thank you very much.
Thank you. Thank you for your kind words, and again, the opportunity to participate in your conference.
You're welcome. Thank you. If there isn't any question, we do not bother Dr. Haynes anymore and say farewell to him. And it seems so. So thank you, Dr. Haynes, and have a good time. And we say farewell to you. Thank you again.
Thank you, and thank you to the organizer. It's a good conference. Thank you.
Bye-bye.
Bye.
Okay. As they say, last but not the least is the last presentation of our symposium, which is Dr. Mona Dehapi. She is a researcher in Macquarie University, and also she's a researcher and interior manager in the Center for Microbial Culture Collection in Tehran University. We can say that, of course, she's a prominent researcher in the field of microbial identification and culture. And interestingly, her presentation will be about the newly emerged pandemic, which is the corona pandemic, and the relationship of kynurenine pathway and COVID-19. We are very glad to hear her presentation. Let's go on.
Hello everyone. I'd like first of all to thank the organizers of this meeting for inviting me here today. I am Mona Dehapi from Macquarie University in Sydney, Australia. The subject of my presentation is possible role of the kynurenine pathway in COVID-19. In December 2019, a novel coronavirus, SARS-CoV-2, was identified as the cause of an outbreak of viral pneumonia in China. The disease later named COVID-19 and subsequently spread globally. It causes acute respiratory distress syndrome, that is a serious lung condition that causes low blood oxygen, organ failure, and death. For COVID-19 and all other infectious diseases, metabolic processes are intimately connected to the mechanisms of disease pathogenesis and resulting pathology and pathophysiology, as well as the host defense response to the infection. The key pathways involved in COVID infection need to be identified more. A better understanding of the important pathways may provide vital insight in earlier prognosis and effective treatment. The kynurenine pathway is the main route of L-tryptophan catabolism, and it has been shown to be a very important pathway activated during COVID-19. The kynurenine pathway plays an important role in the antimicrobial defense and immune regulation. The IDO1 aryl hydrocarbon receptor axis acts by depleting tryptophan to starve the invaders and by producing kynurenine, contributing to the state of immunosuppression with microorganisms. Various viral infections hijack the host immune responses to create a state of disease tolerance through activation of the kynurenine catabolites. In some recent studies have been shown that KP is activated in COVID-19 patients. Holmes et al. Reported that kynurenine-tryptophan ratio is significantly higher in COVID patients compared to healthy individuals. In another study, Thomas et al. Showed that the concentration of kynurenine is elevated in COVID cases. Significant effects of COVID-19 on amino acids, especially regarding tryptophan metabolism, have been recently reported. A recent study conducted by Marin Corral et al. Revealed that tryptophan concentration decreases in patients with severe COVID-19. Some inflammatory mediators, such as damage-associated molecular patterns, interferon gamma, tumor necrosis factor alpha, that are increased during COVID-19 infection, and the hyperinflammation are known to be potent activator of IDO1, the first and regulatory enzyme of the kynurenine pathway. In recent studies, it has been reported that the most commonly seen long-term symptoms in people who have had COVID-19 are depression, fatigue, and cognitive impairment. The kynurenine shunt refers to the increased degradation of tryptophan toward kynurenine and away from serotonin production. Increased IDO1 activity has been related to the depression in studies, owing to both serotonin depletion and neurotoxic effects of KP metabolites. Although there has been evidence of increased KP activation in acute COVID-19, there is no evidence in long-term COVID-19 survivors. Studies in this area can aid in our understanding of the pathophysiology underlying COVID-19 long-term symptoms. In our project, we aim to characterize the new biomarkers by analyzing the blood samples collected at different time points from COVID-19 patients with the asymptomatic, mild, moderate, and severe disease. We have already collected 629 samples from COVID-19 patients. The kynurenine pathway metabolite was measured using UHPLC and GC-Mass. To assess the possible brain damage in patients, we analyzed the brain damage biomarkers such as S100B, GFAP, and neurofilament using ELISA kits. The levels of pro-inflammatory cytokines in patients was analyzed using human cytokine chemokine 14-plex discovery PCR arrays. Our preliminary results showed some variations in KP metabolites during the infection period. ELISA findings indicated that GFAP, S100B, and neurofilament was detected in more than 55%, 17%, and 16% of samples respectively. Different levels of inflammation was observed in COVID patients during the infection period. As a conclusion, the overactivation of the KP in COVID-19 is associated with several health complications ranging from fatigue syndrome, depression, and to neurodegeneration. This research will clarify the involvement of a metabolic and immune collection including kynurenine pathway metabolites, inflammatory mediators, and brain damage markers as a potential index for COVID-19 progression and severity for the first time. Further studies are needed to associate COVID-19 severity with metabolic and immune biomarkers considering patients' backgrounds such as other underlying health complications. Thank you for your attention.
We have many thanks to Dr. Dehaqi for his presentation of this study of her and her colleagues, which was really based on practical needs and was really close to clinical issues. And if we have her online and if she has our voice, we want to thank her and say farewell to her if there is no further questions from the audience. Dr. Dehaqi, do you hear me? Okay, I think we lost her from the online hall. So that's it. That's it for our symposium in this Congress. And we are really glad to be joined by so many good researchers and so many interested attendees that I'm sure there are many researchers among them, among our audience as well. And of course, there have been some shortcomings from our behalf in holding this Congress and holding this symposium, and we apologize for that, but still we are glad to have 5 outstanding lectures and 5 prominent researchers in this symposium. And I myself enjoyed this symposium and learned so many things from that. Thank you very much, and I do not have anything to say unless to thank you. Goodbye.